Thank you to Alex and Lumibird for organizing this symposium. It's very nice to see a full house early in the morning. So let me share with you our first results of this two-year clinical trial. We've been doing YAG laser vitriolysis since 2019. And there isn't a randomized controlled trial, and so we embarked on a controlled trial. So these are my commercial disclosures. And what's today's problem? Well, today's problem is understanding VFO, or vitreous floaters and opacities, in addition to treating them. And why is this? Because most patients are still being told that there's no treatment for vitreous floaters. There's difficulty in sometimes visualizing vitreous floaters. Not everybody has visible vitreous floaters. As we've shown in our publications, floaters do not have to be visible to the examiner in order to be symptomatic to the patient. This has to do with the light scattering characteristics of vitreous floaters. And we are spending, look, I'm doing this now myself, we are spending most of our lives in front of a backlit monitor, and this is the perfect scenario to see vitreous floaters. And it's difficult to correlate the number of vitreous floaters, for example, with symptoms. This is a clear example where you've got an opaque vitreous floaters clearly casting a shadow, but there are patients that have an eye that looks like a fishbowl and they have no symptoms at all. And there are patients that have a clear vitreous and are extremely symptomatic. I'm sure you've come across these patients as well. We have to remember that the vitreous is a matrix of collagen, and as I'll show you later. So why do we need to treat vitreous floaters? Well, vitreous floaters can, apart from the annoying opacity, they can affect our mental health, and also they diminish contrast sensitivity. And why is this? Because they scatter light, as I'll show you in a couple of minutes. So we've published a couple of years ago this new methodology, terminology and methodology for the assessment of vitreous floaters. Why did we do this? Because so far there's no objective way of assessing how vitreous floaters affect vision. And most of the work done so far has been on the back of, or on the basis of contrast sensitivity, and we think we need to go beyond contrast sensitivity. We also have to remember that visual acuity is not a good endpoint, because vitreous floaters are coming in and out of our visual axis. So when the floaters are out of a visual axis, vision is perfect, of course. So why VFO, vitreous floaters and opacities? Because not everybody has what we traditionally consider floaters. Some patients experience an opacity or a film floating in their vision. So we believe that vitreous VFO, or vitreous floaters and opacities, represents better what we are what the patient is reporting. So these are different technologies. I'm not going to go in detail here in this presentation in the interest of time, but these are the different technologies we use. Some of them we borrowed from the refractive surgery field in order to assess these patients. And last year, we published this new surgical technique. It's a variation of limited vitrectomy. We call it therapeutic refractive vitrectomy, and we are removing the minimum amount of vitreous in order to remove symptoms. And why therapeutic refractive vitrectomy? Well, therapeutic because we are enhancing quality of vision and contrast sensitivity. Refractive because we are reducing we are removing the opacities, but at the same time we are reducing optical scatter and high-order aberrations like comas. And vitrectomy because that's the technique. Now, I talked to you about opacities that are not visible to the examiner but are symptomatic. Well, that's got to do with how they scatter light. So there is a forward scatter towards the retina and back scatter towards the examiner. Vitreous floaters and opacity VFO need to induce back scatter in order for them to be visible to the examiner. They induce forward scatter, and that's what makes them symptomatic. So we've got an e-poster, a virtual poster during this meeting, and you can look at all these technologies and the results of therapeutic refractive vitrectomy if you are interested. So let's move onto YAG laser vitriolysis, or YVL, which is what interests us today, what matters today. And this is work that I presented at the Jules Gonin meeting that was in 2021, if I remember correctly. Those were our initial results, first results using this technology. This is the device, what the device looks like. That's in our office. And as you can see, there is a mirror that flips in and out because the illumination follows the same path as the laser. The laser follows the same path as the illumination. And this is one of the technicalities of the system that allows you to go deep into the vitreous. We don't use any YAG laser. I do not recommend using any YAG laser, but you need to use a YAG laser that allows you to go deep in the vitreous, and this is ideal. So this is our study. It's a two-site study. We are the lead site, and we've put the protocol together at our clinic in London. And Jerry Sebak in California is the other side. So the primary objective is comparing floater location, density, and acoustic scatter with ultrasonography, and in patients with myopic vitreopathy or liquefaction, significant liquefaction without or with a vitreous detachment, or in patients independent of what refraction they have, but with a posterior vitreous detachment and a vice ring. So we are also, of course, looking at efficacy and safety. So this is real time. This is myself treating a vice ring, and you can see there in one session, 96 shots. You can do single spot shots or single shots, or you can use multiple pulses. The total energy I delivered was 196 millijoules. This is using a single pulse of 2 millijoules, and you can see there how it is disappearing in front of your eyes. This is real time. This is one session. This is how long it's taking to remove that vice ring, and there you have it. It's gone. And a very, very, very happy patient. And I do surgery as well. I'm a VR surgeon, but it's good to have an alternative treatment. It's good to be able to offer patients choice of treatment. So there you have another patient. This is before and after treatment. That's a flame-shaped hemorrhage, which is independent. It was from the treatment. It was there, as you can see, before the treatment. It's still there, of course, but the floater is gone. The vice ring is gone. This is a patient. This is a myopic patient with a PVD and other floaters, which you cannot see on this color image, but you can see clearly on the video of the actual laser treatment. So you can see that I'm treating a vice ring, and I'm treating also fibrillar floaters. And you can see what I managed to achieve in the first session. By the second session, the vice ring was gone, so I'm treating the fibrillar floaters, and here I'm trying to break up the cortical posterior vitreous. So these are the results before and after YVL or YAG vitriolysis using the SK-VFO test, and again, you can look at the actual test in the e-poster. So these are, as you can see, statistically significant results in the first 38 patients that we treated. And you can see here the 6-month result. We are now going to be reporting very soon on the 12-month results. But most importantly, we are not inducing PVD in patients who did not have a PVD before starting treatment. And we did not induce a single retinal tear. There's some people say, well, but YAG laser induces retinal tears. No, it induces retinal tears if you hit the retina. If you don't hit the retina, it doesn't induce retinal tears. If you drive a car, you can kill people with a car. But if you drive on the road, you're not going to kill anybody. So the same with the laser technology. I have to make it clear that every single patient, before we do YAG laser, whether in the study or outside the study, we do indirect ophthalmoscopy with 360 degrees scleral indentation. So we rule out any tears, and I highly recommend that you do that. And if there are multiple holes with fluid, we carry out retinopexy around those holes before we do the treatment. So there can be complications. There are limitations in this technology, like with every technology. First of all, and this is the most significant in my view, the field of view through the contact lens is quite small. And as I say to patients, remember that I'm going to be looking down or through a contact lens, and it's like looking down the barrel of a gun. It's going to be a small field of view. I'm not going to be able to treat your peripheral floaters. There is a learning curve, especially for establishing the distance between a floater and the posterior capsule, and between a floater and the retina. So when you're doing the lens, you have to be constantly checking that. This is a patient of mine where I've hit the posterior capsule. This is peripheral, so luckily nothing needed doing. The patient continued with more sessions, and this is November 2024. The patient is still being seen, and we haven't had to do cataract surgery. The lens remained clear. This is a patient from Jerry. You can see he's had one PC hit, posterior capsule hit, and one subretinal hemorrhage because of another hit. So the other thing is that floaters need to be visible to you. You cannot treat with these patients that, as I've mentioned before, that are symptomatic but without visible floaters, because there's nothing to target. You saw the laser beams targeted on the floater. You cannot treat peripheral floaters or floaters that are very, very mobile, that come into view and go out of view in a very liquefied vitreous. You cannot treat a detached, wrinkled posterior cortical vitreous. If you have a chance to look at our paper, you'll see that we describe a posterior, detached, wrinkled cortical vitreous as a source of symptoms. And it is not possible to treat, of course, vitreous floaters secondary to interface-related light scattering. So this is what the field of view looks like. So you can compare with an ultra-wide field image. So that's real time. You can even hear the clicks. I hope you don't hear me talking while I'm doing the laser, but there you have the other another example. So well, it's the same patient, different view. You can see the difference in visual field between what I see and what you see before you start the treatment. And this is the contact lens that we use. There are more than one models of contact lens. So we have to remember that we are not treating a cluster of collagen floating in fluid. This is not the way it is, because we tend to forget that. This is what we are doing is we are treating a matrix. We are treating a matrix of collagen fibers, so there's always going to be collagen fibers left. So we are not going to be able to remove absolutely every opacity. And it's important that you have that conversation with the patient. So you can see here, this is a 3D rendering of ultra-wide field. This is a new OCT technology. And you can see here the opacity, and you can see here where the opacity is sitting in relation to the retina. So in conclusion, this is another option for the treatment of vitreous floaters and opacities, and I encourage you to consider it. It leads to objective improvements in stray light values, as I've shown you with the SKVFO test, and imaging results are in alignment with the symptoms, with the resolution of symptoms. In regards to safety, the parameters are within very acceptable limits, and it's an effective approach that enhances both quality of vision, as we've shown objectively, and quality of life, as we've also shown objectively with the questionnaires. This is an ideal treatment for patients that experience few, well-defined and centrally located vitreous floaters. The vice ring is a perfect example. And this is what I would use as, what I would choose as the first patient. This would be the ideal first case, a pseudophakic patient, so you don't have to worry about hitting the lens. and it's more difficult to hit the retina than to hit the lens. And remember that you can defocus with this technology. You can defocus, anteriorly or posteriorly, where in relation to the beam, where the laser creates the plasma. So a pseudophakic patient, a vice ring with complete PVD. I would not treat a patient that had a PVD last week. I would wait 3 months. I would establish a PVD objectively, ideally with ultra-wide-field OCT, indirect ophthalmoscopy with 360 degrees limitation, not slit lamp bar microscopy. That's not enough. You cannot reach the aura with any handheld lens. You cannot reach the aura with ultra-wide-field imaging. The only way on earth to reach the aura in 100% of patients is indirect ophthalmoscopy with indentation. And I tend to use single pulse 2 millijoule as a setting for the treatment. I don't work alone. I'm supported by a big team, and I want to thank again the other speakers and Lumibird for this invitation.
Thank you, Paulo. We have time for a few questions. First, let's begin. In myopic patients, we have usually many floaters. How do you assess the floaters you are going to treat?
That's a very good question. In real life, what you end up treating are the floaters that you can see through the lens, which are usually the most symptomatic. But in myopic patients with myopic vitreopathy, you are always going to leave the peripheral floater. So it's important that the patient understands that, because you are not going to be able to, until we have a better lens or different technology, we cannot reach the peripheral floaters. What I tend to do is I tend to ask the patient to move the eye up and down, right and left. And if the vitreous is not too liquefied, I can target some of these floaters while they are within the field of view of the lens.
And then we have a question from the audience concerning vitrectomy. Do you treat central floaters or even in periphery?
In the vitrectomy?
Yeah.
In vitrectomy, you end up removing absolutely every floater, because when the patient is in a supine position, the floaters automatically group in front of the macula. So we do the TRE, therapeutic refractive vitrectomy. We only remove the opacities. We play with the endolight, and we just remove the peripheral vitreous opacities. I don't induce PVD. If it's not there, I don't go for the peripheral vitreous, and I leave vitreous behind the lens. We believe that it does slow down the progression of lens opacification, and it could also reduce the risk of glaucoma in the long term.
Okay, one question.
I think Abri from Austria. I think case selection is very important in the case of the patients, because if they are very critical. I had a case of, I did a lot of lasers, and some complained after having done the laser. They had before focal disturbances, now they have a net. It's important to inform the patients it could happen afterwards. It might be leftovers. We will never be able to remove all these disturbances.
Absolutely, I fully agree. As I said, you have to have a discussion with the patient. That's essential, because you are not going to be able to remove the peripheral floaters. But as I've shown you there with the results of our study, this is why we're doing the study, to have objective assessment of quality of vision and objective assessment of quality of life. And patients are happy, but they are happy as long as you've said, as you've explained, if you've explained to them in advance so they don't get disappointed. If they want complete removal of vitreous floaters or opacities, if they are complaining of symptoms from the vitreous cortex that's wrinkled, then they need a vitrectomy. Well, that's a different proposition. We do that as well, of course, but it's important to be able to offer both. Every time I have a patient with floaters, I discuss both approaches. I discuss three. There's nothing, which is what you've been offered until now, observation, because most people, at least in the UK, are being told that there's no treatment, which is wrong, and it's unethical, because there is treatment. You agree or not, but there is treatment. There is vitrectomy, and there's laser, or laser and vitrectomy.
Hi, a very nice talk. I'm from Delhi, India. I have a question. So patients come to us who are extremely symptomatic, but we don't see so many floaters. But when I do an ultrasound and increase the gain, I see a lot of floaters.
Yeah.
So do you treat them or you have to operate them?
Yeah, that's a very good question. We treat them. I recommend you to, if you have a chance, have a look at our poster, and you can download our paper from PubMed. We published it in Retina. We treat those patients. It's more and more common to see. Usually, in our experience, these are usually young patients. Some of them are on antidepressants. The difficulty with those patients is that when you don't see any opacities, and we do the SKVFO test, we do ultrasonography as part of the SKVFO test, we do infrared videoscopy as part of the SKVFO test, and we objectively assess the light scattering characteristics, because we need to justify surgery in those patients, but surgery is the only solution for those patients.
Thank you very much.
Because you really need to be able to target the opacity.
Thank you very much for Professor Stanga
for
being
having
with
me.
us. It has been amazing. So we can move on with the second lecture from Alejandro Filloy, that is going to give us a lecture on subthreshold retinal laser treatment as well as recommended treatment settings. Please, Alejandro.
Thank you, Marco. Good morning. It's a pleasure to be here. I'd like also to thank Lumiver for organizing this symposium and you for assistance. Hope we make it worth your time. So we are going to talk very well about the indications and techniques for the main indication of subthreshold in the following talks. I will stick to the basis, basically definitions, basic guidelines on treatment parameters, and a few controversies with examples. Those are my disclosures. So first of all, the basics. We call subthreshold laser, at least when talking about retinal disease, about, under the name subliminal or whatever other commercial denominations, a laser that works under this. First, it provokes a response from the targeted tissue, in this case RPE or Muir cells, in the form of these tissues producing anti-inflammatory or anti-exudative molecules that are going to have a local therapeutic effect. And as well as that, it must be invisible once delivered at any given moment. I mean, short, middle, long term. You should see no spots on the fundus, OCT, whatever. You should only see the effects, the results. And it's a surgical procedure. I mean, like in all surgical procedures, you're inducing a small controlled dose of damage, which correctly administered might result in a positive result. So it's operator-dependent, experience is key, and the most standardized it can become, the better. Safer, more reproducible, easier to learn. And that's pretty much the reason to be of this society we created a few years back, the Subthreshold Ophthalmic Laser Society, in order to bring a little bit of order, a little bit more of scientific soundness to this practice. That's why the first brainchild of this association, so this society, was our guidelines, coordinated by Dr. Jab Chablani, which are pretty much summarize this. We'll go over them one parameter by one. This letter to the editor is a short paper, very quick to read. It's freely available. So we are going to go through these settings you can see here one by one, maybe from less to more controversial. First of all, the duty cycle. Virtually everyone nowadays is using a 5% with a 200 millisecond pulse duration, which means an effective laser time of 10 milliseconds. Spot size between 100 and 200. Anything smaller, it takes forever. Anything bigger, we have inefficiency issues due to the heat dissipation, so stick to 200 at most. And treat it with dense patterns, one spot next to each other for what we were mentioned before, so you can recruit as many cells as possible to work for you. Single spot will not do much because it will only excite a few cells, which will hardly cause any significant response. But recruiting a large number of cells is the key for results. So, and stepping into muddy territory, what about the power? I gotta say that the SALT guidelines were elaborated by a large number of investigators, about 30, 40 people from all over the world, different groups, and very importantly, using different devices. And we agreed in mostly everything. This had the lowest degree of consensus, although most of all liked to titrate. Quite a lot of experts prefer to use fixed parameters. This is an issue that it's not yet clear. But why do most of us did we defend titration? Because it takes into account especially the variability of energy absorption between patients, mostly depending on the degree of pigmentation of their RPE at the fundus, and also the weakening of the laser cavity with time, which must also be taken into account. What does it mean to titrate? It means that you test on the macular periphery of the patient with increasingly powerful subthreshold spots until you see a very faint reaction, a barely visible burn, barely beta B, by the way, sorry about that. And lower 50% to that power, to that minimum visible power, and that's the power you will use in your treatment. I'll show you an example later about the how-tos. Just to mention about the conclusion about central zeros, we agreed that subthreshold is a perfectly good technique both for chronic and acute forms. It's a good first-line treatment. There is a lot of literature about that. We will talk plenty about it. That you should treat generously, widely, large number of spots around the leakage point, and you can check for result after 6 or 8 weeks. DME, the other great indication, more or less the same. Useful for center and non-center involving in or without combination with intravitreal drugs. You need to treat all the edematous area and check in a couple of months for results, maybe even a little more. DME is way more complex than CSE in its variety of manifestations, so it's a little bit more difficult to get the grasp of it regarding indications. And now, just to finish, a couple of controversial experts. First, the fovea. Should we treat the fovea, or better said, should we treat through the fovea? We said this is a harmless laser. It does not burn, does not cause scars, at least if you use the proper settings. Well, we have 2 responses for that, and they are both right. First, you can spare the fovea. It's very small. You can spare those 4 or 5 spots you would need to cover it, and the other 490 spots will do the job. Or if you're an expert, you have hundreds of cases in your record without scars, you can treat through it safely. There is literature backing both options, so it's kind of a fake controversy. Let me show you this example. So we would like to try this area of diabetic macular edema. So in order to obtain a successful treatment, we should apply something like this. So there's a few hundred spots. You will agree with me that there will be hardly any difference between doing this and doing this. This handful of spots will not mean a difference. As long as you treat enough around with the proper power, you will get your results. And then we talked about titration and why do we do it, but not how. Because the problem of titration comes always the same. What is a barely visible? How should I measure it? Under which magnification? Which lens? How much illumination? I'm afraid we don't have a solid response for that yet, so experience here comes again. What I can tell you is something that when you select a power before treatment, your machine is probably going to display you, depends on your device, but I think modern devices, all of them do it. It's going to display the fluence, which is the energy you're going to deliver per surface depending on all the parameters, spot size, power, whatever. And I'm proposing this classification, which comes completely from my experience, but it's a good basic guideline. If anything under 12 is absolutely safe, between 12 and 20 it's overwhelmingly safe, and over 20 starts I put in red, the danger zone. It's safe for most cases, but it's when you need to be sure. If you, after titration, result with a 20 joules power in a pigmented patient, make sure that the titration was made properly. Here you can see, for example, in this device, how the titration just before before treatment is displayed, I like, when I select my power and I'm ready to treat, I like to give a quick glance to it, just to make sure I'm in the safe zone. I mean, for example, somebody has messed with the slit lamp and changed the size of the spot, it might alter your fluence. So an example of titration, I don't know if we're going, well, let's see if we can see it. Increasing power. There we go. And I don't know if you can see it, it's very faint, but in the fourth spot, you can see a very faint change. From that, we change to 50% and start treating next to the other, as we mentioned. When you start, maybe it's a good idea to lower not to a 50, but to a third, just because matter of subjectivity. And if you get good results, at least get no scars, you can safely escalate from there to 50%. Conclusions. Guidelines and consensus are key to provide reproducibility and soundness to any technique, especially surgicals, and we believe the SOLS guidelines to be very valuable in this matter because of its many contributors, which I insist have come to the same conclusion using different devices. When you're learning, when the first case is when in doubt, remain in the safe side. Do not treat the phobia, be generous with the power reduction, and you will build a good experience on a solid basis. You can always retreat. I invite you to join SOLS, visit our website, where you will find quite a lot of educational material on this matter and more. Thank you.
Thank you very much, Alejandro. Just one question, because of time, from the audience. What is the maximum power that could be used when we treat, when you do the titrate?
Well, the guidelines for Lumiere recommend that if you reach 1,200 milliwatts, 1,200, you should not go any further. I have treated, which would mean a power of 600. I have treated very few people over that power, mostly very likely pigmented patients, almost albino, but those are the exception. If the final result of titration is 600 or something around, just check it again.
Just another brief question from the audience. Which lens do you recommend?
I use the Volk Area Centralis, contact lens, of course. I use the Volk Area Centralis, but any contact lens that encompasses from arcade to arcade should work with you.
Very good. We can move on with, and it's a pleasure for me to introduce Sébastien Guigou with half-dose PDT or subthreshold laser for CSC treatment. Please, Sébastien.
Thank you, Marco. Thank you, Lumiere Medical, to give us the opportunity to discuss subthreshold laser. And we are going to talk about central serous choroidopathy. So what is CSC? First, about diagnosis, you have to use multimodal imaging. That means fundus photography, autofluorescence, OCT, and especially choroidal assessment, and angiography, and especially ICG. You will see to guide the treatment. Of course, we have on one hand acute CSC. Usually, these are young males, type A personality, steroid use, sleep disturbance, or PDE5 inhibitors. And on the other hand, we have chronic ones. Usually, these are older patients, over 50 years old, after 6 months of duration, multiple and or diffuse leakage points, and we have a lot of recurrences. The CSC is within the pachychoroid spectrum. It's important to have all these disorders in mind when you do the imaging, because in our purpose, you have to take a look at neovascularization, choroidal neovascularization, because it's very important, as we will see further. You don't have to treat them with laser, but it's the indication of intravitreal injection, of course. So what are the current options? Previously, we had the PLACE trial in 2018, and the gold standard was half-dose PDT in chronic CRC. But from now, we have many papers with the yellow 577 nanometers laser and subthreshold technique. So these are the options. We don't use anymore eplerenone or anti-VEGF, as I said, in this indication, and we have to choose between PDT and subthreshold laser. At this time, our first treatment is subliminal laser, yellow one, guided by ICG, because it's effective, non-invasive. Yes, we have a slower response in comparison from the PDT, but it's repeatable. You don't need a nurse, and of course, you don't have supply shortage as we have with Visudyne. So let's see a case. It is an acute CRC with the hotspot, as you see. We apply the treatment in all the area you see on the ICG, and this is the follow-up, and after 8 months, we obtain the good result with vision and anatomic result. On the bottom left, you see the autofluorescence at the end of the follow-up. You don't have any scar, which is, of course, very important with the subthreshold laser. So how to treat? How does it work? As Alejandro said, it delivers sublethal thermal stimulation to the RPE. It triggers cellular stress response, regulates growth factors, modulates cytokines, activating heat shock proteins, and we obtain anti-angiogenic action and a restorative effect on the retina. Then we don't have no destruction or inflammation, and thank you, Alejandro and Marco, for your great work with the salts. We follow this protocol as you described, so I can skip because of time. I will just emphasize the step of titration. You don't have any standard about the power, as Alejandro said. You have to adapt with the RPE pigmentation, media transparency, retinal health. And then when you have obtained the very visible impact, you reduce the power from 50% to apply the subthreshold treatment. In this way, you avoid over-treatment or under-treatment. Why yellow one, yellow laser? Because it matches oxyhemoglobin absorption. It's well absorbed by the melanin, and you avoid xanthophyll pigment. So it's less toxic and more efficient. And we can add, we have less glare with cataract also. So what is our treatment? This is the screenshot. We target the anti-hyperpermeability area on ICG. You could treat the central fovea only if you are experienced. After a learning curve, which is not very long, I must admit, we use 160 micron spots with the Mozart laser and area centralis lens, 5% duty cycle, 200 millisecond exposure, and dense confluent pattern. First, you titrate, as you see on the video. Then you reduce the power, and in some cases, you have to retreat after 2 or 3 months of follow-up. So take-home message, it's crucial not to miss neovascularization during the diagnosis and imaging. Here is a case with a hotspot. We have treated with the laser, and this is the poor outcome, because in fact, when we reviewed images, it was type 1 choroidal aneurysmal neovascularization, and we should have injected this patient. So don't miss neovascularization. It's a key point in these diseases. When you have a good selected patient, you do titration as you see along the arcade, superior arcade. Then you treat with the pattern all the area of hyperpermeability with the dense confluent pattern. And here is the follow-up with the dry retina. And you see on the bottom left, one hyperfluorescence on the titration. That means then I have reduced the power and then reduce again of 50% to apply the confluent pattern. In this way, you don't have any scar. In conclusion, check for pachychorid and neovascularization. Treat early to avoid RPE atrophy. Subliminal laser is our first-line treatment. Then you can consider high-fluence PLT. Both reach the same visual acuity at the same result at 6 months of follow-up. Subliminal laser is less invasive. You have no photosensitivity, and you don't need any nurse. Recurrence is possible, and you can retreat. Thank you very much.
Please, there are some questions from the audience.
Thanks for your talk. May I ask you, how many times do you treat with laser before you move on to 3, 4?
Usually I manage 2 treatments, and if there is a recurrence, I change. I consider again angiography to look for neovascularization first, and usually then I do PDT, half dose.
After 2 sessions?
Yeah.
Advised early treatment. How long do you wait for spontaneous resolution of the
Yeah.
before treatment?
First, I always wait 3 to 4 months to help dry of the retina. Then I treat, and I usually see my patients 8 weeks after the treatment to assess the result.
Hi, this is a question to you as well as the previous speaker. I've been using the yellow micropulse laser for last many years, and what I found after following the SALT's regime of 50% reduction, if you do it at 50% in Indian eyes and you do an autofluorescence later on, you can actually see the marks by autofluorescence. So I don't do 50%. I don't think that's correct for Indian eyes. We bring it down to anything between 35 to 40%. I don't know, what's your experience?
In fact, in central serous choroidopathy, I follow this protocol, and I'm quite happy without any scar. If you really take care of the titration, of course, and if I obtain during the titration just a visible impact, I reduce first my power, and then after I reduce of 50%. So it's important to assess the titration not very far from the area you have to treat, with just one spot after one to correct and choose the correct power. Alejandro?
Just a comment on the last question. You are absolutely right in doing autofluorescence after your treatment, especially the first one. I didn't mention it, but that's probably the best way to check that you are not over-treating, because some faint spots may pass unseen. So well done about that. And it's very important to do as you do audit your own results and adjust the titration. The main problem with titration is that we cannot yet reach a consensus of what barely visible burn is. So your barely visible might be 1,000 and mine might be 800, and that might be the difference. So if you see some spots, just lower your 50% to a 30%, and you will most likely be all right.
One observation that you get very disappointed when you think you have waited a long time to see the titration. Then you treat, and then you talk to the patient, and by some reason you take a photo, another photo, and then you see the titration. So you have to wait minutes sometimes. So could you say a time frame to keep guidelines for how long to wait to see the titration?
Usually, it's a direct visualization. I never go above 1,200 milliwatts for sure. Even it's not visible, this is our maximum step. And autofluorescence could be a good assessment if you want to see the scar. And maybe I could add in DME, may have more visible impact than in CRC. But maybe Marco will say it.
So yes, we'll move to Marco's
Thank
talk.
you very
We'll
much.
be a little bit tight on schedule, and he will talk to us about. Marco will talk to us about the convenience of laser for today's diabetic patients.
Thank you very much for the opportunity, and thank you, Lumibird, for this great symposium. It's a pleasure and a privilege to be with you today. So probably I will give you some clues about also the titration and how to evaluate correctly what it is visible and what it is not. But nevertheless, we will start from the very early beginning. Where does our problems related to the use of laser for diabetic macular edema come from? They come from the protocol I that evaluated the prompt versus deferred laser treatment in addition to ranibizumab, and the results at 5 years show that the results were somewhat similar. But when considering the two groups, especially those with best corrected visual acuity lower than 9 letters, the area under curve saw the longitudinal evolution, and in terms of functional outcomes was superior the deferred treatment compared to the prompt treatment. And they concluded that the laser therapy has therefore been taken from the position of first-line recommendation and is rather considered to be harmful. And following this finding, our EURETINA guidelines concluded that laser treatment and Bistone should be effective in the management of diabetic macular edema, but in the era of anti-VEGF is not the standard of care anymore. And they speak about relative indications, and these relative indications include the laser application for the vasogenic subform of diabetic macular edema, and with the laser especially localized to the microaneurysm or the leaking capillaries. So it means that we have performed fluorescein angiography for sure. And from the other side, eyes affected with the diabetic macular edema with a central subfoveal thickness less than 300 microns or with the persistent vitreomacular adhesion. So there is no support for the evidence that laser would add more benefit to the pharmacotherapy. Nevertheless, from the other side, there is our experience. We have a patient like this with this leaking microaneurysm and this extrafoveal edema. If we want to treat this patient, where do we treat? We treat this area. And I treated this patient with a focal laser treatment localized, and especially in those area of the microaneurysm. And we see that there is almost a complete resolution of the fluid within 1 month, and there are no substantial scarring defects at the fluorescein angiography. So we can perform this laser in a quite healthy and safety approach. From the other side, there is the preferred practice pattern coming from our friends from the United States, and they suggested that the role of anti-VEGF in non-centrally involved in diabetic macular edema has not been studied. So the focal or the grid laser treatment is recommended, still recommended in this scenario. We are speaking about a recommendation of 2024. And in this case, a modified ETDRS laser treatment is suggested with less intense laser energy, greater spacing, directly targets microaneurysm, and avoiding the foveal vasculature within at least the 500 microns from the center of the macula. And for the first time, it was introduced the concept that the systematic review suggested that the subthreshold laser approach is as effective as the traditional laser surgery. And we are speaking about the preferred practice pattern. So, and this findings comes from a prestigious and well-conducted study, the Diamond study conducted in the United Kingdom that compared the outcomes from the standard threshold versus the subthreshold approach for diabetic macular edema of less than 400 microns in terms of central subfoveal thickness, and the outcomes were BCVA in the subthreshold micropulse laser was equivalent to standard laser. And for secondary outcomes also, like the central retinal thickness, visual field, the quality of life, driving legibility, they showed no significant difference between the two treatments. So from the other side, the advantage are no retinal burn or scan. This means, as we will see, to preserve photoreceptors, to preserve the RPE and the whole neurosensory retina, especially so we can treat those areas with a very limited risk. And from the other side, there is the rationale of using the laser subthreshold approach, because it promotes the production of these shock proteins from the retinal pigment epithelium, which reduce the transcription of VEGF and other pro-inflammatory molecules. And also, it appears useful to activate the Mueller cells, which drive almost the whole accumulation of fluid, both intraretinal and subretinal. And there is an hyperexpression of, so it's able to reduce all the biomarkers of activation of the Mueller cells, like KIR4.1 or RANS, MPF, the ligand of FAS, and also suggesting this anti-inflammatory effect. And how do we perform this treatment in diabetic macular edema? Here is a case of a patient with a 2032 visual acuity. He has previously received 7 anti-VEGF injection, and we decided to perform a subthreshold micropulse laser because he almost only showed this serious neurosensory detachment associated with some intraretinal fluid. And in this case, we obviously try to avoid the central fovea, as suggested by Alejandro a few minutes before. And then our approach is a fixed approach, as we will see, with a power of 250 milliwatt, 200 microns, 200 milliseconds in terms of exposure. The spot diameter is 160 microns, duty cycle of 5%. And as you can see, this is a high density pattern of confluent laser foci on the fluid area. And it's much more appropriate to say on the wall leaking area. So in this case, we treated, as my personal approach, with a single confluent spot the macular area, and with a pattern approach, the wall leaking area. And we actually, in our clinic, we analyzed the outcomes also by the use of an AI assisted approach that almost defines not only the volume of the neurosensory detachment, but also the intraretinal fluid and also the number of hyperreflective foci. And we have observed how 1 month after the subthreshold micropulse laser, we have an increase in terms of visual acuity, a substantial reduction of hyperreflective foci. And also the intraretinal fluid was improved, as in this case. We have the same treatment, 2050, this patient, and after 1 month, 2025. And this is the AI-based analysis that suggested the reduction in terms of hyperreflective foci, a reduction of intraretinal fluids, and a preserved outer retinal layers integrity. What do we see if we don't have structural OCT, or what do we see when we analyze the patient with a slit lamp approach? And then you can clearly see this just 1 month after treatment, the substantial improvement, especially in terms of hard exudates. And we all know how difficult it is to obtain such a result, also with different pharmacological approaches. So there is a good clearance of hard exudates, there is a good clearance of the hemorrhagic component as well in this case. But what about safety? So we all know that these specific damages that we observe at the level of the outer retina are strictly dependent of different parameters: the power, the time of the exposure, the duty cycle of the laser. And when we perform the titration, obviously we have to obtain the visualization of a barely visible spot, but barely visible is just related to our personal visualization of the patient that depends on several parameters. So to have a correct evaluation of this, we have to move toward a multimodal imaging approach. And as in this case, we have a 800 milliwatt, 1000 milliwatt, or 1200 milliwatt approach, and you see how they are definitely visible, and these are the changes that have been obtained both at the level of the outer retinal layers of the EZ and RPE, EZ, RPE, and also within the outer nuclear layer. And with the 1200s, we have more evident damage at the level of the outer nuclear layers. But this patient, for example, has been titrated. We have no clear evidence of any sign of a barely visible spot, but when we look at the multicolor imaging, we start to evaluate two different spots that were not clearly visible on our ophthalmoscopic examination. Something is slightly visible on autofluorescence. When we move toward the OCT, this patient was treated for a serious neurosensory detachment. We have some focal changes at the level of the RPE and the ellipsoid zone. And also, this is another case where when we titrate this patient, we have this the evidence looking at the multicolor imaging. And when we're looking specifically at the photoreceptors, so outer retinal layers, and we can compare the images before the titration and after the titration, we have that in this area, we have a complete loss of visibility of the photoreceptors. And this is not clearly evident when we perform with a fixed regimen, the one I have suggested before. So the number of photoreceptors in that area remains almost unchanged. So our current approach with the 557 yellow laser is a high-density, fully confluent fashion in the whole macular area using fixed parameters, a spot size of 160 microns, the exposure time of 200 milliseconds, 5% UV cycle, and the power of 250 milliwatt. This is an extremely safe and effective approach, as seen in this area, as in this case, as suggested by the Light Society as well. So, like key takeaways, the laser treatment has a crucial role in the management of both CI and centrally involving, non-centrally involving diabetic macular edema, SMPL, so the subthreshold approach, using fixed parameters appears effective and able to reduce the potential risk of iatrogenic damage due to wrong titration. And in other cases, to evaluate the efficacy, we can always look at our AI-assisted analysis. It may be useful in determining the efficacy of SMPL, especially to discover its potential anti-inflammatory effect or the direct RPE stimulation. Thank you very much for the kind attention.
Well, thanks a lot. I think we are already late, out of time. I don't know if we can get 5 minutes of grace, or if that's not possible.
So just, we have to conclude. So thank you very much for coming. It has been definitely an amazing symposium. Thank you once again to Lumibrid for giving us this opportunity. And thank you all for having such a very overcrowded room. It has been a pleasure to have you all. And enjoy the rest of the meeting. See you.